So that's a really big part of working with somebody to explain what's going on for them and not keeping that hidden under the covers and pretending that that's not there, because it can be confronting. So say somebody has an anxiety disorder, it's fitting in what they're experiencing with what we know. And we don't know everything, but what we know, okay, this symptom here is part of that disorder. Can you see how that fits in there? And then maybe they have their own names for it. So just working with them and working together to try to come to some common understanding. It's tricky because sometimes you can use terms that they go, oh, that's scary. I don't experience that, or they feel stigmatized by that. And you really have to work through and explain that, no, I don't mean that, for example, anxiety is something there's something wrong with you because of that. Everybody experiences it, normalizing, we call it, talking about the evolution of the anxiety system, and just really trying to explain things in a way that they will understand for their kind of level of exposure to these terms as well.
I used to, as a student, we used to get pages of things that we would have to tell the patient. We're talking 3 or 4 pages after an extraction that you have to say to the patient, 3 or 4 pages for how they should brush and what they should do. It's in fact, one of the specialists once told me you have to give a 10-20 minute presentation for each patient who is special needs. These days what I do is I actually try to simplify things. I actually give them quite a small list of things to do. I try to use as simple words as I can. For instance, if I had a patient who had very dry mouth, and that's actually one of the things that can affect your teeth, is I go, well, look, all I want you to do for the next week is I want you to chew some sugar-free gum. I want you to start sipping on your water rather than drinking it. That's all I want you to do in terms of changing your habits. Next week I might introduce using bicarbonate soda with water just as a rinse after every meal. And it's just one of those things you want to just increase slowly by slowly every time. It's about giving simple information, not giving them a complex information, because not everyone's going to hear everything that you have to say on the very first appointment.
At the Mater we have lots of women who don't speak English come in, especially in the public system. So we often have to use an interpreter to relay information through. So first of all, the first barrier is that the interpreter might not understand what you're saying and interpret something completely different. They're not meant to, but it's a person, so they're always going to put their own input into it. So getting past that barrier, often you have to use quite easy to understand and not colloquial language, so something that's very standard language throughout. And then secondly, you have to make sure that the patient actually understands what the interpreter said. So we do that by getting them to repeat back to us what they want. Often we use visual clues, so actually acting out what you want done and showing them, oh, the baby needs a temperature check, so you put the thermometer under their arm and you go see the number, and then you write down the numbers that it needs to be between. You do very obvious big movements because that helps them understand exactly what you want.
Well, particularly with children and adolescents, the gold standard approach is family-based therapy. And we have the best outcomes for the treatment of eating disorders in children and adolescents through involving the family. So I suppose we'd really be kind of drawing on the parents and trying to help them have a more accurate understanding of health and trying to facilitate conversations between them and their children. So it's the messages actually coming from their parents on a more regular basis. With adults, I suppose it's generally trying to understand what's important to that particular person. So some people who maybe do have a very rigid black or white way of thinking, it can be helpful to kind of pull out some medical data. So they've lost weight and they think that means that they're healthier, but we can kind of go through and show them what's going on for them medically and give them some hard evidence that they're actually more compromised and less healthy now that they've lost weight. For somebody else, it might have been that they were hoping to lose weight so that they were more popular or felt like they had more social interaction with people, and we can sort of identify that now that they're kind of eating at home or they've got a lot of anxiety around food, that they're actually feeling less good about themselves and they're more constrained socially. So I suppose it's trying to understand what is the component of health that's important to that person, and then trying to find ways of showing them that maybe their view of health is a bit too narrow and there's these other areas of health that we need to be working on.
So for those who were born in refugee camps and then they came over here, they don't even understand their own language in terms of writing. They may be able to speak it. So even if we have everything translated, they can't read it. So then we realize, pictures is worth 1,000 words. So if we put more pictures and actually physically show them what they need to do, then that might be a better form of education, and than just giving them a sheet to take home without any further explanation. Then there's the different group of local Australians, but who the homeless groups or the vulnerable groups who don't have a language problem, but they may not have the opportunity to have been educated about how to look after themselves, or they may have other life issues that's more important for them to actually try and overcome, and health is probably, especially oral health, is probably bottom in their list, and also so I think again for the different groups, depending on what their issues are, we need to tailor our messages and health promotion sort of materials and sessions specific to that particular cultural group or particular vulnerable group, because we can't use the same method and same material across the board. I don't think that will work, particularly after working with them for so long. Then you sort of realize for different groups you really need to develop different strategies. That way they can actually understand you, and they can actually appreciate that we're trying to assist them to gain good overall health, so that they don't need all these treatment later down the track.
Yeah, and I think for a lot of our young people, just really being persistent with achieving their goals, and just not giving up, but also being honest with them, and holding true to the promises you make them. Yeah, I definitely think being an Indigenous person myself allows me to just get along well with our Indigenous clients. In saying that, our youth team is a mixture of Indigenous and non-Indigenous workers, which is great as well, because even though we're a youth service within an Indigenous medical centre, we do not, although we primarily provide a service for Indigenous youth, we're not restricted. So we work with all different types of youth, regardless of cultural background. And I guess for me, having lived experience myself, it does help me to relate to my clients, but also more than just understanding, I guess, what our clients have been through, what their parents have been through, but also understanding just lingo and how Indigenous people talk, and like to muck around and pull jokes on each other all the time. So there's that aspect, regardless of what nationality or where you come from, people have a unique way of talking. And that's a big rapport building factor, whether you work in Indigenous specific field compared to as a refugee specific field. Both those will have their own way of talking, and if you're able to understand that language, then you're able to be more a part of that environment.